Start. So basically, we'll come to know what kind of NIV, portable NIVs you will use and which conditions you will use. First is most commonly we'll see sleep apnea patients where you will use CPAP. CPAP is nothing but expirative positive airway pressure, in which continuous pressure is delivered throughout inspiration and expiration. So basically, it is used for type 1 respiratory failure or OSA patients. So minimum you have to keep 5. And how much maximum you can keep in OSA patients? What you will do, you will go into auto CPAP mode. So in auto CPAP mode, pressure will vary from 5 to 14, 20 like that. In that you will see, my computer will generate data itself where you will come to know almost at what pressure 80% of AHIs will be abolished. So example 8 or 10 like that. So next time what you will do, initially you will start with 5 and maximum will keep in auto CPAP 15. But after looking at the graph for 1 week, you will come to know at around 8 or 9 like that, it will be abolishing almost 80%. So you will keep plus or minus 2 pressure, 7 to 11 like that. Just I am giving example. In that range, you have to set. And what about BiPAP? BiPAP here, as the name itself indicates, you have both two pressure, EPAP plus IPAP. EPAP is during expiration and IPAP is during inspiration. So the difference between IPAP and EPAP is called pressure support. So why you will use? So in expiration, OSA, what will happen? There is a collapse of airway during inspiration. So you need pressure to open that one. So pressure will be lost if you are giving 6 while going to airways, it will be lost up to 2. And expiration also, it will continuously deliver. But some people, what they have difficulty in tolerating expiratory pressure. So what you will give, you will translate the pressure slightly drop during initiation of expiration. That is called a flex. C flex. Slides are not moving. Hello?
Yes, moving, sir.
Moving now. Okay, okay. So some people they will have lot of difficulty while pressure is generated during exhalation. So in such cases, you can use A flex, C flex, C flex. In CPAP, it is a special setting. There is slight pressure drop during initiation of exhalation. That is called C flex. A flex is it will facilitate some people, if you give with pressure, they will not tolerate. They will have claustrophobic like that. So initiation of inhalation also, it will slightly. For example, you have kept 7, 8 like that. So it will not give 7, 8. It will produce slight drop 6. After that, it will build up. That is called A-flex, drop during inspiration and expiration. This was there in Philips machine. No, it is not there. In ResMed, they have EPR, exhalation pressure relief, it is called. So it is nothing but C-flex mode. And BiPAP, basically what you are giving in EPAP or CPAP, you are giving continuous pressure during inspiration as well as expiration. So what will happen during exhalation? Your breathing muscles have to work with pressure. So it may produce pressure on your breathing muscles. So what you will do in BiPAP, you will give higher pressure during inspiration, and expiration slight pressure will be there, so which will help assist respiratory muscle pushing their effort. So workload on respiratory muscle will be less. So basically it is used in type 2 respiratory failure. And one more important thing, T rise. What is this? The speed at which inspiratory pressure rises to set pressure, or how fast it is rise. This time is very important. Why? If you give T rise rapidly, so inspiratory pressure rises very rapidly during inspiration. So inspiration time will be prolonged. So in what conditions you will use? just like neuromuscular disorders, all those things. T rise should be slow in COPD patients because they have more problem during exhalation. So T rise should be slightly slow. And one more thing is I is to E ratio. It will be there in, of course, advanced BiPAP machines in ventilator also. Normally it is 1:2. I wrote wrong. It should be 1:2. So expiration should be slightly prolonged when compared to inspiration. Whereas in some conditions like pneumonia, all those things, you will give reverse. It should be 2:1. It is called inverse ratio ventilation. And one more thing, in BiPAP, you can give fixed backup rate. Suppose if patient is not breathing properly, so machine will deliver with pressures. So this is called spontaneous time mode. What is the advantage? I will tell you later in my later slides. One more setting is AVAPS. It is called average volume assured pressure support. Why you call this one? Especially in OHVS patient, what they are unable to generate sufficient tidal volume. So what you will do if you give suppose 6 EPAP and 12 IPAP, they will not be comfortable in breathing with that one. So what you will do if patient is initiating breathing with pressure, so pressure support will be delivered at around, for example, 6. If patient is unable to initiate breath effort, so higher pressure support will be delivered to attain minimum tidal volume. So EPAP is fixed between 6 to 8, whereas pressure support volume is between 6 to 14. So how much will be the inspiratory pressure? 6 is EPAP and pressure support varying between 6 to 14. So it will be 12 to how much? 20. And one more thing, here minimum backup rate is set. For example, 12. And all by default, all BiPAP machines will have 12 minimum backup because which is minimum sustainable to deliver sufficient oxygen to your brain and heart. And one more advanced version was there. In heart failure, what will happen? The heart is unable to pump blood properly. So there will be delay in reaching oxygen to the brain. So what will happen? Whenever oxygen does not reach the brain, it will hyperstimulate respiratory center. And whenever it reaches, it will suppress. So almost like chain stop type of breathing. So if you give fixed respiratory rate, what will happen? Whenever patient is not breathing properly, it will not be able to deliver. Whenever patient is breathing perfectly, it will deliver more. So it will cause more harm. So what do you call that mode? It is called adaptive servo ventilation. Here EPAP is same fixed, but it can be varying. Whereas in AVAPS mode, EPAP is fixed. Of course, some advanced ventilators NIV are there where EPAP is also variable. But most of the times it will not be. EPAP will be fixed. Here in adaptive servo ventilation, you can fix EPAP between 5 to 12. And pressure support is also variable between 6 to 12, 14 like that. And what about minimum backup respiratory rate? That is not fixed. So what is the drawback? Those who have heart failure with ejection fraction greater than 40, they will have waxing and waning kind of respiration. So this one works very well. But if somebody has very weak heart, less than 40, if you are not giving minimum backup rate, depending on patient effort, suppose if patient is unable to initiate respiration, so you will not deliver any breathing. So patient may die also. Some trials have shown that patients had a very high risk of mortality, especially with EF less than 40. So what you will do in such kind of patients? You will give BiPAP setting with spontaneous time mode. What does it mean? Whenever patient is not breathing, ventilator will deliver. In these patients, most of the times, as the heart is very weak, they will not have any sufficient respiratory drive. Okay. So what you have understood so far? Whenever OSA patient comes or patient with type one respiratory failure, you will use EPAP. EPAP is continuous pressure you are doing, both inspiration and expiration. So some people they will not tolerate. They will have claustrophobia, especially during inspiration or expiration. So for them, what you will do instead of giving faster pressure, slow initiation of inspiration, there will be slight pressure drop and expiration also. It is called aflex. If there is a pressure drop only during exhalation, most of the patients they will have problem during exhalation because with pressure it is coming, so they will not be able to cope up with it. So C-flex is helpful. What about BiPAP? Because you are giving pressure difference between expiration and inspiration, so it will help respiratory muscle to generate sufficient strength. So mostly in type 2 respiratory failure you will be using. And minimum EPAP setting is 6 always. And IPAP can vary between 12 to 20. And pressure support is difference between EPAP and IPAP. One more thing is T-rise time. So how much fast you are delivering inspiratory pressure. This is very important, especially COPD patient, you have to keep it slow because they have problem in exhalation. So if you don't give sufficient time for exhalation, they will have auto PEEP generation and it will have so many deleterious effects. And one more thing, inspiratory to expiratory ratio is normally 1:2 by default. If suppose ARDS patient, all those things is there, you can use reverse 2:1. It is called inverse ratio ventilation. And BiPAP comes with backup rate. For example, 12. Spontaneous time mode is there means it will assist patient also. Whenever patient is breathing, it will not deliver. Whenever patient is not breathing, it will deliver. But without ST mode, what it will happen, whether patient breathes or not, it will give 12. That is the drawback.
सर कैन यू रिपीट दैट लास्ट पॉइंट सर? एसटी मोड में बैकअप रेस्पिरेटरी रेट रहता, अगर एसटी
बैकअप
मोड में
रेस्पिरेटरी
था
रेट रहता। विदाउट एसटी मोड में क्या है, पेशेंट ब्रीथ करो मत करो उन्हें 12 दे देता। एसटी मोड में पेशेंट ब्रीथ करा तो नहीं देता, पेशेंट 6 टाइम करा तो उन्हें 6 टाइम देता। विदाउट एसटी मोड है तो पेशेंट ब्रीथ करो मत करो उन्हें 12 टाइम देता, तो पेशेंट वेंटिलेटर एसिंक्रोनी होता।
ओके ओके
वो ड्रॉबैक है। और एक क्या है, एवाप्स में क्या है, pressure support vary करे because some breath they will have good effort, some breath they will not have good effort. तो जब breath effort कम है तो pressure ज्यादा देना ना support, so that is called AVAPS, average volume assured pressure support. And here also minimum backup rate is 12. So what is the drawback with one more word, adaptive servo ventilation? Here it is EPAP is variable, IPAP is variable, and respiratory rate is also variable. Minimum backup नहीं देता इन्हें. Suppose if patient is not breathing, he will not give. Ventilator will not give. So they may die also. Especially heart failure patients with EF less than 40, it is absolutely contraindicated. Above 40, you can give. It is called adaptive servo ventilation. Okay. Heart failure में क्या है, heart blood is unable to reach the brain. So whenever it is reaching, it will produce normal drive. Whenever it is not reaching, it will produce hyperventilation drive. To avoid that one, you will vary expiratory pressure as well as pressure support. And respiratory rate is also variable. So minimum breath required is 12. Here patient cannot breathe, so it will not recognize patient is breathing or not. So it will think patient is breathing minimum 5, 6 like that it will give. So which is very dangerous because adaptive servo ventilation minimum backup rate you cannot fix. That is the problem. And one more thing, mask size, how tight it should be. It should just admit one finger within the mask, neither too tight nor too loose. And length should be from the here bridge of the nose to the chin. That one should be the size. So standard is medium size fits all. That is also important. And non-portable, I mean portable BiPAP, they have leak compensation. Okay. Ventilators, they will not have leak compensation.
सर
That is,
व्हाट इज लीक कंपेंसेशन सर?
सपोज 1 लीटर बाहर जा रहा था, उसमें कंपेंसेट हो जाता, इसमें ना होता वेंटिलेटर में।
सर अपन अब ये अडेप्टिव सर्वो वेंटिलेशन नहीं यूज करते ना सर ज्यादा?
नहीं 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 यूज करते, ये ड्रॉबैक है। पहले जब स्टार्ट करे थे, दे आर गिविंग लेफ्ट एंड राइट टू ऑल हार्ट फेल्यूर पेशेंट। सडनली दे नोटिस सडन डेथ, क्या हुआ बोल के वो रिसर्च करे तो दोज हु हैव लेस देन 40, जस्ट मोटा मोटा कट ऑफ है, आई थिंक अप टू 35 आल्सो वी कैन गो, उन लोगों में ये बैकअप रेट नहीं रहता तो सडन डेथ हो जा रहे, तो इट इज वेरी डेंजरस बोल के बैन कर दिए।
सर अब ये डिफरेंट टाइप्स ऑफ मोड, एक है प्रेशर सपोर्ट मोड पीएस मोड, एक एचटी मोड,
हम्म।
और कौन से है सर? हम यूजुअली प्रेशर पीएस मोड देते हैं सर पेशेंट्स को, या एचटी मोड अगर से जरूरी है, ज्यादा मोटे है, ओबेस, ज्यादा CO2 रिटेंशन है तो एचटी मोड देते हैं,
एसटी मोड देते
नहीं तो पीएस मोड अगर से उन्हें कंट्रोल कर सकते,
हैं।
बेटर
हम्म।
टॉलरेट कर प्रेशर सपोर्ट मोड।
हम्म। और ज्यादा, बहुत ज्यादा ओबीस है, बिल्कुल ड्राइव नहीं आ रही हो तो एवाप्स देते, एवरेज वॉल्यूम एक्यूट प्रेशर सपोर्ट। क्या है ना ये स्लाइड में, ई पैप फिक्स रहता 6 to 8, प्रेशर सपोर्ट वेरीज बिटवीन 6 to 14। सो क्या होता, मिनिमम टाइडल वॉल्यूम डिलीवर होता। वही बैपैप पे दे दिए वो तो पेशेंट का टॉलरेंस नहीं रहता, पेशेंट वेंटिलेटर सिंक्रोन ही होता, या पेशेंट के एफर्ट के हिसाब से वेरी करता, तो बहुत कंफर्टेबल रहता OHVS वालों के स्पेशली।
तो ये 3 मोड है ना सर, पीएस मोड, एचटी मोड, एवेप?
नहीं नहीं, सीपैप बाईपैप, बाईपैप में कौन सा है,
हम्म।
एसटी मोड रहता, विदाउट एसटी मोड रहता, और
हाँ,
एक एवाप्स है। एवाप्स में एसटी मोड नहीं रहता, मिनिमम बैकअप रहता।
और प्रेशर सपोर्ट?
हम्म। अडाप्टिव सर्वो वेंटिलेशन में सब कुछ वेरी रहता, ईपैप भी वेरिएबल, आईपैप भी वेरिएबल, रेस्पिरेटरी रेट भी वेरिएबल।
हम्म।
तो पेशेंट जनरेट ही नहीं कर रहा हो तो उन्हें 12 देता ही नहीं, मिनिमम 12 ब्रेथ्स होना पेशेंट के सर्वाइवल के लिए, ने 5 6 जो भी है उतना दे देता, तो इट इज नॉट सफिशिएंट। सो पेशेंट विल हैव हाइपोक्सिया होने से सडन एरिथमियास ट्रिगर होते, वाई सिंपैथेटिक स्टिमुलेशन होके, इसलिए ज्यादातर कार्डियक डेथ्स रात में ही होते। वेंटिलेटर मास्क और पोर्टेबल मास्क में क्या डिफरेंस है?
सर वेंटिलेटरी मास्क इज नॉन वेंटेड, पोर्टेबल बाईपैप का मास्क इज वेंटेड ना?
देख के बोलो।
वेंटिलेटर को 2 ट्यूबिंग्स रहते हैं ना सर, एक इंस्पिरेटरी और एक्सपिरेटरी,
हम्म।
तो नॉन वेंटेड रहता वो, उसमें
हाँ।
वेंट नहीं रहते तो भी चल जाता।
हाँ चल
पोर्टेबल
जाता,
में खाली एक ही ट्यूब
एक ही
रहता हो
रहती,
आने
हाँ
जाने
वेरी
का,
गुड, इसलिए वो उसको खोलना पड़ता।
वेंटेड रखना पड़ता उसको।
वेंटेड रखना पड़ता और लीक कंपेंसेशन अच्छा होता। सिंगल ट्यूबिंग है ना, इसमें डबल ट्यूबिंग है, लीक कंपेंसेशन नहीं होता। साइज तो फ्रॉम ब्रिज ऑफ द नोज टू टिप ऑफ द चिन, ये आइडियल है। अब वो सब नहीं, वो तो मिनिमम मीडियम साइज फिट्स फॉर ऑल, एंड योर मास्क शुड नॉट बी टू टाइट, जस्ट वन फिंगर जाना, तो वो सफिशिएंट रहता, पेशेंट कंप्लायंस अच्छा होता।
सर अब ईपैप में अब ड्यूरिंग एक्सपिरेशन ऑल्सो देयर इज ए पॉजिटिव एयरवे प्रेशर,
हम्म।
पॉजिटिव प्रेशर इन द एयरवे है।
हाँ
तो पेशेंट जो है एक्सहेलेशन करना हो अगेंस्ट दैट प्रेशर।
हाँ, तो इसीलिए तो आईपैप देते वो सपोर्ट नहीं होना बोल के। थोड़े लोगों को क्या है वो थोड़ा प्रेशर ड्रॉप कर लिए तो टॉलरेट कर लेते।
नहीं, अब इंस्पिरेशन में आईपैप के टाइम पे ठीक है, 12 के साथ अब एयर एयर चले जा रही है अंदर,
लग
एयरवे ओपन
जाएगा।
कर रहा है, ठीक है। अब एक्सपिरेशन के टाइम पे 6 प्रेशर है रहा एयरवे में, तो
हम्म।
उन्हें
मजीज को असिस्ट करता हूँ, स्ट्रेच होते ना
करता है।
तो
हाँ हाँ।
ज्यादा फोर्स लगाने नहीं देता।
अच्छा अच्छा।
वो ड्रॉप नहीं रखे बोले तो फिर ओवर स्ट्रेच होके और ज्यादा हाइपर इन्फ्लेशन जैसा हो जाता है, एम्फाइसीमा जैसा।
हाँ।
फिक्स रखे वो तो मिनिमम स्ट्रेच होके आइडियल स्ट्रेच पे वो है ना। आइडियल स्ट्रेच अंडर स्ट्रेच हुए भी तो ब्रीथिंग सही नहीं होती, ओवर स्ट्रेच एम्फाइसीमा में भी ब्रीथिंग सही नहीं होती, डिस्निया होता। वो कंप्लायंस का ग्राफ वो था ना। हम्म।
यस सर, यस।
हम्म। और कुछ तो भी प्रेजेंटेशंस बना के बोलो, ठीक है।
आज मेरा प्रेजेंटेशन अच्छा हुआ सर आज।
हाँ सर का वो उनको गूगल रिकॉर्डिंग करो बोलना था सर को।
आप ही बोलना सर अब वो।
बोलता हूँ ठहरो।
आज वो स्ट्रेप्टोकाइनेस पे देना नहीं देना,
हम्म।